I'm Dr. David Morwood. I'm a board-certified plastic surgeon, and this is Your Health radio and television program. Thanks very much for joining us. My next guest, the very special, wonderful Dr. Mary Kay Brewster, obstetrician gynecologist. Dr. Brewster, thanks very much for being here.
Well, thanks for having me.
Dr. Brewster, there's a lot of misconceptions about what an obstetrician gynecologist does and how you get to be an obstetrician gynecologist. If we could start off by talking about your average week. What kind of issues do you see? Who do you see in the office? How often do you go to the hospital, in the operating room? And then if we have a moment to talk about delivering babies, and we're going to talk about hysterectomies, etc. But let's talk a little bit about, say, what your average week is like.
Well, I did take a hiatus from obstetrics because my children were young and I was hardly home. And during that time, I was in the office for 8 hours a day. And as much as I love my perimenopausal women, it gets a little tiresome, I guess, doing pap smears and talking about hormones, etc. So I restarted obstetrics lately in January of this year, and it's a great break.
So, Dr. Brewster, so being in obstetrics means, for our listening and viewing audience, being in obstetrics means you deliver babies.
Exactly.
And you help guide women through the gestation period and help them deliver their babies.
Exactly.
So how often do you go to the hospital, and do you only do deliveries at the hospital, and how often do you help with deliveries?
I only do deliveries in the hospital, and I'm not a fan of home birth for a multitude of reasons. It really varies. It took me several years to figure out why I would be so busy one week and completely not busy the next. For instance, September 25th, the babies that were born or due on that day were conceived on New Year's Eve.
Wow.
So I had a whole bunch of ladies due on September 25th or 26th because they all got pregnant on New Year's Eve. And
amazing.
So then I would have, several weeks where I wouldn't do a delivery, and then I'd have 5 deliveries in a week. And that's kind of how obstetrics is. It's completely unpredictable. You can be at your office, just seeing patients, and you get a call from the hospital. We need you to come in right now. Mrs. So-and-so is 10 centimeters. She just got here and she feels she needs to push. And that's kind of the fun part of it. Sometimes it's, when it's 4 a.m., it can be tiresome, but for the most part it's exciting and you feel really vital and important.
Of course. Well, Dr. Brewster, most of the audience listening and viewing know by now that I'm a plastic surgeon, but I recall in medical school, the first time I helped to deliver a baby, it was a C-section, and I thought, really, this is the miracle of birth. It's unbelievable. It's amazing, don't you think?
That I was a medical student. I was on a pediatric rotation, and I was part of the nursery, and I was called in for a cesarean section. And I went in, and all I could do was just focus on the delivery and the obstetrical part of it. And my resident kept telling me, come, pay attention, you're on the pediatric part of the team now. And I was just so amazed with starting a surgery and having a baby come out at the end of it.
It is amazing. And so you are back in obstetrics now, in addition to being in gynecology. Mm-hmm. Great. Well, let's talk briefly, if we can, about the gynecology aspect of your practice. There's a lot of misconception about what a gynecologist does. Can you tell us about what maybe your average week is like related to gynecology? What sort of problems and issues do you see in the office?
Well, most of what I do in the office on a day-to-day basis is routine health care. And I have quite a few young, healthy women that come in because they need to get their birth control pills refilled. However, I have a substantial part of my practice is women that are approaching menopause or are in menopause or just after. And I would say that I spend a majority of my counseling time talking about hormones or talking about what effects hormones have on women. And then I do surgeries, of course, hysterectomies, all kinds of cervical procedures because of human papillomavirus and cervical dysplasia, and some sterilization procedures some infertility surgeries, and then some cancer procedures.
I see. Now, Dr. Brewster, there is one area or one issue, the ectopic pregnancy, where obstetrics and gynecology really seem to come together. Now, can you define for our audience what we mean by ectopic pregnancy?
Yes, it's when the embryo is implanted outside of the uterus, and that's typically in the fallopian tube, but it can be on the ovary, or interestingly, there was a case recently in the news where a woman went to near term with an ectopic pregnancy implanted in her peritoneal cavity. So implanted in her abdominal cavity, the placenta is somewhat like a cancer that it can grow into and acquire a blood supply. And this baby developed and grew inside her peritoneal cavity, and she had a term baby, basically.
Biology is amazing, especially with deliveries and babies growing, etc.
It's usually not that happy, though. It's usually in the fallopian tube, and the fallopian tube is like a little teeny garden hose. And once the baby gets to about 6 weeks, it exceeds the size of the tube, and the tube will burst. Fortunately, we have, for women that have access to good health care, they will often present with pain. And we have excellent imaging studies now, and we can often see a mass in the adnexa on the side of the uterus, and they can have often a laparoscopic surgery with often preservation of the tube and the ovaries.
And that's something that you do?
Yeah, it's one of my favorite surgeries.
Okay, so let's talk about that for a moment. Now, an ectopic pregnancy that you would see, it's when the embryo starts to develop within the tube, and we expect the embryo to be implanted in the uterus, right?
Right.
That's the normal, healthy way.
Exactly, and an embryo implanted in the uterus is prepared, the endometrial lining has been, do you remember your health movie?
I'm trying to remember.
Where the endometrium plumps up in preparation for the developing embryo. The embryo comes down the tube, implants in the uterus, acquires a blood supply, and then grows to maturation. The fallopian tube sometimes malfunctions. The little cilia, which are little hair-like fibers that sort of brush the embryo down into the uterus, sometimes there's a problem. Sometimes it's because of a prior infection. Sometimes it's a dysfunction of the tubal motility, or the brushing effect. And the tube will, or the embryo will implant in the tube, acquire blood supply, the cells will multiply and grow. And I've had many cases where you can actually see a beating heart in
Amazing.
A beating heart in the fallopian tube, but the fallopian tube is no womb.
Okay.
And so when women come in with pain or bleeding, we will often get an imaging study, usually through the emergency department. And when an ectopic pregnancy is identified, sometimes we can use a medication called methotrexate, which is an injectable chemotherapy agent. Sometimes because of different, characteristics of the embryo is developed too far, and then we must proceed with surgery. If the tube is not ruptured, if we don't see fluid, which is usually blood, in the pelvic cavity, then we can proceed with a laparoscopic surgery. And that is just a brilliant invention and a fantastic advance in healthcare.
Okay, so Dr. Brewster, I want to talk about that a little more. So laparoscopic surgery, as opposed to the traditional or classic open type of surgery or laparotomy, is what now? So,
well, some of my patients have come to me and asked me, do you do laser surgery or that bloodless surgery? Which is basically, I think they're referring to laparoscopic surgery. Typically, the camera is introduced through the belly button, and once the camera is in there, first you fill up the abdominal cavity with a CO2 gas, and it kind of plumps up the abdomen almost like a Jiffy Pop, and then you put the camera in, and once the abdominal wall is puffed up, you have this magnified view of everything. And it's really fantastic because everything is so clear, and you have as long as things are in somewhat good control, you have tremendous, or I shouldn't say, if there's no rupture of the tube, you have complete control over your operative environment with really an incision that's about 5 millimeters.
See, this is amazing to me because when you talk about introducing a camera through the belly button and seeing everything inside, it sounds really like Star Wars, don't you think?
Well, I always tell patients it's kind of like Star Trek when Bones does the little woo thing.
Right.
But yes, you have a small tube that goes through the belly button that allows a camera, much like a periscope, to look around. Once you have visualization, introducing the other tubes, they're like a hollow straw, and those go in different sites, usually under your bikini line. You can then put instruments in, and you kind of work like with chopsticks, and you can move things around. The anesthesiologist will tilt the patient up and down, and you can often see a fallopian tube, and it's very dramatic when you see this bulging tube with this embryo in there, and you can then incise the tube with, it's a cautery. Patients might call it laser, but a cautery incision, so there's no bleeding. Often you can even use a suction irrigator, an Esat-Dorsey suction irrigator, and use the pressure of water to blow the embryo out of the tube. Sometimes you have to remove it with a grasping forceps. And then you can cauterize with a laser. Usually I use an argon beam laser, the implantation site of the embryo. And then you leave the tube open. It's called a linear salpingostomy. And that is the ultimate preserving fertility surgery. They used to try to close it with laparoscopic sutures, and they found that scarred more. So you control the bleeding, leave the tube actually open, and then it heals by secondary intention.
So do women ever ask you if they can become pregnant again even following that surgery? Or is that fallopian tube still functional?
It can be, but definitely they're at increased risk of having a subsequent ectopic. And always I advise the patients to get early ultrasound to confirm the pregnancy's in the uterus. It really varies, but I try when possible to do the linear salpingostomy as opposed to resecting the fallopian tube, leaving the woman with a single tube, which is still better than none. But especially if you have some sort of prior impetus to cause an ectopic pregnancy, like chlamydial infection, which damages tubes almost specifically, or pelvic inflammatory disease, or a ruptured appendix, or endometriosis, all different benign but pathological gynecologic conditions, I try to leave both tubes in there.
Okay, so that's what we call laparoscopic surgery. Mm-hmm. And Dr. Brewster, I don't mind telling our audience, I understand that you're really good at it. You're an excellent surgeon, and you're really an expert in that.
Thank you.
I don't mind telling our audience. So what I want to do is talk a minute about the anatomy, and then I want to talk about what else you can do with the laparoscope in addition to ectopic correction or ectopic surgery. So there's paired ovaries, right?
Right.
Which are connected to the fallopian tubes, which leads to the uterus, which then leads to the vagina. Is that right?
Yes.
And the cervix is in the middle.
The cervix is the bottom of the uterus. It's part of the uterus, and it's at the top of the vagina.
Okay.
I told you earlier, my favorite surgery is laparoscopic assisted vaginal hysterectomy, and that can be with ovarian removal or not. It depends on the patient's age and her medical situation.
So that's amazing to me. So with the laparoscope, you can remove the uterus, which is a hysterectomy.
Right.
So how's that work?
Well, Dr. Laughlin, Donnell Laughlin, she and I just did a case the other day, and this was a patient who had quite a large uterus and had a very bad problem with heavy bleeding and painful periods. And we were able to do the umbilical incision and then two 10 millimeters, so 1 centimeter, about that big, incisions on each side, and then a 5 millimeter, just about that big, incision in the midline. And through those incisions, we were able to take down, she wanted her ovaries removed, she was close to menopause. We were able to take down the ovarian blood supply, the round ligaments, the broad ligaments, all the way down to the uterine arteries of the uterus. Make a bladder flap so that we didn't involve the bladder in our surgery unintentionally. Retract the bladder upward. Take the uterine serosal tissues and push those down. And then when we converted to the vaginal part of the surgery, we had just a couple of clamps to get up to the uterine arteries and then take the uterus
amazing.
out.
And that's all through the laparoscope and with the little periscope that you said you introduced.
Exactly. And this
That's
was
amazing.
this lady went home from the hospital. She actually had a bladder suspension by an expert urologist, Dr. Fleming.
Dr. Fleming, this is the day for me to bring my pelvic expert. Well, Dr. Brewster, we only have about a minute left, so I want to make sure that I give out either your phone number or your website, and then I have another question for you. So how can patients contact you?
My office phone is 649-0111.
And you're right here in Monterey.
Right on
That's
El Dorado.
Dr. Mary K. Brewster, obstetrician gynecologist. Now, we only have a few seconds, but I understand soon you're going to be doing some skincare or some...
I will start working with the Keller Medical Institute, and I'll be there twice a week to primarily do the smart lipo, which as a plastic surgeon, I'm sure you're familiar with liposuction.
I am. That's very exciting.
The smart lipo is an awake, no anesthesia liposuction.
Excellent. Dr. Mary K. Brewster, obstetrician gynecologist right here in Monterey. I'm just so happy you could join us. I hope you come back again. We could talk about any of these issues, I'm sure, for hours.
Thank you.
Thanks very much for coming. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and this is Your Health radio and television program. We're going to take a very brief pause for a very good cause. Thanks for joining us.